Thank you very much, Dr. Mazzei. I appreciate the invitation to come to this lovely community. It's too bad we have to have a medical meeting. Go ahead with the first slide. What I'm going to discuss are what the coronary arteries look like in patients with fatal coronary heart disease. Before getting into what they actually look like, I show this slide to point out that it takes a good deal of narrowing or luminal obstruction in order to diminish flow through a tube, through a pipe, through a coronary artery. Here, for example, is a diagram showing that it's necessary to obliterate 3 of the 4 quadrants of a coronary artery or pipe in order to diminish flow through it. If one has a circle and divides it into 4 quadrants, a little over 3 of those quadrants have to be obliterated in order to diminish flow. This slide is based on a study done about 10 years ago and shows the amount of narrowing or the number of coronary arteries necessary to be narrowed greater than 75% in cross-sectional area in most patients with at least fatal coronary disease. If we just look at the 3 major arteries, the right, the left anterior descending, and left circumflex, most patients with at least fatal disease have at least 2 of these 3 arteries, any 2, narrowed greater than 75%. It's relatively infrequent to see a patient, at least with fatal coronary disease, with only 1 artery so narrowed. We live in a quantitative era, 1983, of course, not a qualitative one, so to speak. So it's really not enough to know whether a patient has 1 vessel disease, 2 vessel disease, or so-called 3 vessel disease. And in recent years, what we've been doing, at least from an anatomic standpoint, is not only asking how many of these arteries are narrowed greater than 75%, but we've been dividing them into 5-millimeter segments and asking how many of those segments are narrowed 76 to 100%, how many 51 to 75, how many 26 to 50, and how many 0 to 25. One of the purposes of this, of course, is to try to get an answer to why some patients with severe coronary atherosclerosis have angina pectoris, while others have acute myocardial infarction, while others have sudden ventricular fibrillation. Does the answer reside in the status of these coronary arteries? Now, one cannot get that answer by dividing patients into 1, 2, or 3 vessel disease. If one does that, they all look the same. The first group of patients we studied were those who might be called sudden coronary death. The sudden death part of it is easy, of course. A few years back, I had a trip to the Soviet Union. My neighbor asked me, well, why are you going to Russia? And I said, well, I'm on a delegation to study sudden death. He said, well, you couldn't have picked a better place to go. But he wasn't talking about sudden coronary death, of course. And to say coronary, I think it's essential that at least one of the major arteries be narrowed greater than 75% in cross-sectional area. This slide summarizes observations in 31 patients who died suddenly from coronary heart disease. This diagram shows that on an average, the right coronary artery in most adults is about 10 centimeters in length. The left anterior descending also about 10 centimeters. The left circumflex in most of us, 90% of us, gets very small after the left obtuse marginal. It's about 6 centimeters. The left main about 1 centimeter. So what we have are 27 centimeters on the average of these of the 3 major coronary arteries, or 4 major, to examine. And since we divide each centimeter into 2 5-millimeter segments, we have 54 segments on an average to look at per patient. Now, in these 31 patients, 54 segments per patient, Look at this number right there. 36% of these segments were narrowed 76 to 100%, and this is entirely by atherosclerotic plaque alone. Another 34% narrowed 51 to 75%, which means that 70% of these segments were narrowed greater than 50% in cross-sectional area. When I was in medical school, I was taught that coronary atherosclerosis was a focal process, meaning, I presume, that it's present in one artery, not present in another, or it's present in one segment of one artery and not present in another segment of that artery. Well, look at this number, 7%, which means that only 7% of those segments were narrowed 25% or less. In other words, very unusual to have a normal segment. Now, this slide analyzes the same patients, but it looks at the individual coronary arteries in these patients who died suddenly. The point of this is that the amount of narrowing or the lack thereof in these three arteries, the left anterior descending, the left circumflex, and the right, severe narrowing or minimal narrowing, it's parallel. And that's a principle of coronary disease, in my opinion, with relatively few exceptions. If one deals in groups of patients, 100 or 30, there's some individual exceptions to this, of course, but in groups of patients, the amount of narrowing in those three arteries is similar, irrespective of the subset of patients one is dealing with. The left main, fortunately, less narrowed. Another principle, I thought a principle, of coronary heart disease that I was taught when in medical school was that there was more narrowing in the proximal halves of our coronary arteries than in the distal halves. Now, what this slide shows is the three arteries and the percent of the segments in those three arteries which are narrowed greater than 75%. And this shows that if one divides the right coronary artery in the proximal half, the distal half, LAD in the left circumflex also in the proximal and distal halves, there was no significant difference in the amount of severe narrowing, at least in these patients dying suddenly, in the proximal compared to the distal half. Next. The next subset of patients we studied were those with acute myocardial infarction. And here's a group of patients, in contrast to the first group, who made it to the hospital, made it to the coronary care unit, and died subsequently. The sudden death victims never made it to the hospital. And yet, a dramatic difference in their clinical appearances, but yet the amount of narrowing by atherosclerotic plaque in each of these groups was similar. The percent of segments, so this is based on 27 patients, narrowed 76 to 100%, 34%, and percent segments narrowed 51 to 75%, 38%, and only 5% were narrowed to 25% or less. One of the things that this points out is that coronary atherosclerosis is a very diffuse process. To believe it's a focal process is to believe a myth. Now, this slide is similar to the one shown with the sudden death victims. On the horizontal axis here are these categories of cross-sectional area narrowing, and on the vertical axis, the percent of 5-millimeter segments so narrowed in each of these four arteries. Again, these three arteries, the left circumflex, the right, and the LAD, the amount of narrowing or the lack thereof in those three arteries is similar. The left main, again, 10% of the segments were severely narrowed. This slide in the acute myocardial infarction victim simply shows, as it did in the sudden death group, that there was no significant difference in the amount of severe narrowing in the proximal, shown here in red, half versus the distal half, shown in yellow, in these three arteries. In other words, the amount of narrowing was relatively uniform in the coronary tree. Now, this slide is based on a study a colleague and I did a couple of years ago. We asked two questions in this study, and that is, if you compare patients with anterior wall acute myocardial infarction versus patients with posterior wall acute myocardial infarction. And these were patients with their first myocardial infarction based on 50 patients. Which group has the worst coronary narrowing? Well, what we found in this study was, to my surprise actually, the patients with posterior or so-called inferior myocardial infarction had a greater degree of coronary narrowing than did the patients with anterior wall infarction. This particular slide just looks at the percent of these 5 millimeter segments which was narrowed greater than 75%. The other question we ask in this study, does it mean if a patient has a posterior or inferior wall infarction that the right coronary artery is more narrowed than the other two? Or if one has an anterior wall infarction, does that mean that the left anterior descending artery is more narrowed by atherosclerotic plaque than the other two? Well, we found, at least in the posterior wall or inferior wall group, that there was no significant difference in the amount of narrowing in the left anterior descending or the dominant posterior or the other posterior artery. The amount of narrowing in all three of those arteries was relatively similar. So why these patients had a posterior infarction versus an anterior, I don't know. In the anterior group, it was true that the left anterior descending artery was a little more narrow than the other two. But again, all three were considerably narrowed by atherosclerotic plaque. This slide does not include the amount of narrowing by thrombus. Now, the next subsets of patients we studied were patients with healed myocardial infarction. We studied here 36 patients, took the two extremes. One group of 18 were patients who had a myocardial infarction which healed, and thereafter they were left with chronic, severe congestive heart failure which became intractable and finally fatal. The other subset of patients we chose were individuals who also had an acute myocardial infarction which healed, but thereafter they never again had a symptom or sign, actually, of myocardial ischemia. They never again had angina, they never had a subsequent myocardial infarction, and indeed they died from a non-cardiac condition, usually cancer. So here's an asymptomatic group symbolized by this diagram, and here is a group symbolized by this diagram who had severe dyspnea, severe chronic congestive heart failure. Now, which group would you think would have, logically, the most coronary narrowing? What we found was, if we looked at the percent of segments here, narrowed 76 to 100%, 29% here, 31% here. Percent of segments narrowed 51 to 75, 37%, 35%. In other words, no difference. All right. These patients had severe failure because they had a very large infarct. These patients had a small infarct, but the amount of narrowing was similar. It does not appear that one can correlate the size of an infarct to the amount of coronary narrowing. But there's really no such thing as a small infarct, a small heart attack. These patients may have just as much narrowing as the patients with so-called massive or large infarcts. We also have studied a group of patients who had true left ventricular aneurysms at sites of healed myocardial infarction. And these patients, when we looked at the percent of 5 millimeter segments, narrowed 76 to 100%, 33%, which was relatively similar to the other patients with healed myocardial infarction. A final group of patients with angina pectoris. Now, how does one get a group of patients whose only manifestation of myocardial ischemia is angina pectoris to study at necropsy? Well, this is not easy, of course, because most patients with angina die suddenly, and then at necropsy they're put in the sudden death group. Or they have an acute myocardial infarction, and then at necropsy they'd be put in the acute myocardial infarction group. So in order to get a group of patients whose only manifestation of myocardial ischemia was angina, we took a group who died at coronary operations or had a cardiac catheterization accident. and this is based on 19 patients. These 21 patients. These patients would fulfill most individuals' definition of unstable angina. These patients had terrible angina. They all underwent cardiac catheterization, all had normal ejection fractions, normal cardiac outputs, good contracting left ventricles, and yet look at the amount of coronary narrowing in these patients. Some of these individuals took 50 nitroglycerin tablets a day. Whether this data is applicable to the patient who walks in your office with one angina attack a week or one a month, I don't know. This is really severe angina. Look at this number. That should be 47%, but 47% of these segments were narrowed 76 to 100%. 47%. Another 29%, 51 to 75%, and 11%, 0 to 25. So one cannot correlate the amount of myocardial damage to the amount of coronary narrowing. Here we have a group of patients with beautiful left ventricular function, and yet just absolutely terrible degrees of coronary narrowing. There's another difference in this angina group compared to the other subsets described, and that is this. Not only were these three arteries, the left circumflex, the LAD, and the right, the amount of narrowing or the lack thereof parallel in this group, just like in the other groups, but unfortunately these three arteries were joined by the left main, so that in these patients with unstable angina, over 40% had severe narrowing of the left main coronary artery. Now, a number of groups have shown that there is a high frequency of significant narrowing of the left main in patients with unstable angina, and this study also shows that. Another thing interesting about this angina group, at least unstable angina, is that this is the only group that we've studied in which or in whom there was more narrowing in the proximal halves of the major arteries than in the distal halves. The only group. The others, the distal halves, were narrowed just as much as the proximal halves. So if somebody asked me, well, why do patients with angina do pretty well after a bypass operation, I would have to respond, number one, left ventricular function is good, pretty good in most of these individuals. And number two, there's less narrowing in the distal halves versus the proximal halves of these arteries. So there's a good opportunity to get a conduit in there that has a good runoff, at least much better than in the other groups. Now this montage is sort of a horror show, really, because each one of these sections is based on a histologic examination of one 5-millimeter segment in one patient. Now this was an individual who unfortunately had unstable angina. Let's go down the right coronary artery and try to find one of these cross sections that's pretty wide open. Look at the left main here, severe narrowing in this particular patient. The left anterior descending. Well, that fellow right there is pretty good. Left circumflex, way out here, so virtually occluded there. That's what the patient and that's what the doctor and that's what the nurse is up against in taking care of patients with coronary heart disease. This slide summarizes what's been said. We've studied by this, what I call quantitative approach, 129 patients with fatal coronary disease. That was nearly 6,500 5-millimeter segments examined under a microscope. And 35% of those segments were narrowed 76 to 100%, and another 36% narrowed 51 to 75, which means that 71% of these segments were narrowed over 50% in cross-sectional area. We did have controls for these studies, and only 3% of the segments in the controls were similarly narrowed. When we looked at the various subsets of patients, the amount of narrowing in the sudden death group and the acute myocardial infarction group were similar. 36% and 34% of the segments were narrowed 76 to 100% by atherosclerotic plaque alone. The patients with healed myocardial infarction as a group, whether they were asymptomatic after the acute infarction or whether they had chronic congestive heart failure with an aneurysm or without an aneurysm or with an aneurysm, they had as a group a little less coronary narrowing than these victims. The patients with unstable angina had the most narrowing of all. 47% of those segments narrowed 76 to 100%. We did one other thing in this group, and that is give a score to each 5 millimeter segment, so we could have a single score for each patient, the amount of narrowing. We gave a score of 1 for a segment narrowed this degree, 2, 3, and 4. Now what that means is that most of these patients had a score in the groups, or a score of 3.0. Now that means that the average amount of narrowing per 5 millimeter segment was 67%, whereas in the controls, 32%. Now what does that really mean? It means this, that if you look at the average 5 millimeter segment out of a total of 54 segments, the average amount of narrowing in a victim of coronary heart disease was 67%. Now that's an awful lot of cross-sectional area obliterated. I think when one looks at a coronary angiogram, one has to keep in mind that the contrast material is flowing through this space here and does not necessarily depict the underlying amount of plaque. In the control group, half of that, 32% of the area, a cross-sectional area, was obliterated, a striking difference. Another question we've asked 2-3 years ago was, is there another factor other than narrowing which might affect flow to a myocardium? We wondered about size of a coronary artery. Obviously, by this diagram, here is a cross-section of what might be called an artery, which is narrowed greater than 75%, and here's another one. But if you have to have coronary disease, of course, it'd be much better to have a big artery than a little artery, because a lot more flow could go through that area than through that area. So we determined the size of coronary arteries in these various subgroups by studying the first 5 millimeter segment of the right, the left anterior descending, and the left circumflex coronary arteries, getting a square millimeter area, the average of those 3 arteries. And what we found was, yes, indeed, there were differences in the sizes of coronary arteries. The patients with angina had the smallest in this group, and the patients with healed myocardial infarction and chronic congestive heart failure thereafter had the largest arteries. But what was responsible for these differences? And we found that 95% more or less of the difference was due to heart weight. The patients with the smallest hearts had the smallest coronary arteries. The patients with the largest hearts had the largest coronary arteries. So we concluded from this analysis that if one looks at anatomic determinants of myocardial oxygenation, that the size of the coronary artery is proportional to myocardial mass, so they cancel out one another, and one is left with a degree of luminal narrowing of the coronary arteries as the major factor. Now, what use does this information have as obtained from a study at necropsy to the live patient? Coronary arteries are studied in live people, of course, by injecting contrast material. Does this quantitative information based on study of cross-sectional area narrowing have any use in interpreting these coronary angiograms? I think it does. What I've been talking about, again, is cross-sectional area. Coronary angiograms are read by diameter reduction, not cross-sectional area. But if one has a 50% diameter reduction on a coronary angiogram, that is based on examining that area of narrowing compared to the adjacent area, which is assumed to be 100% wide open. But is that the case? Is coronary atherosclerosis in the symptomatic patient really a focal process? Does a plaque really occur in one side and not in another? No, I think it's unrealistic. The real world is this, and that is, if one has a narrowing, that narrowing is simply compared to an adjacent area, which is assumed to be normal, but in actuality almost surely is also narrowed. So this, if one could compare it to the internal elastic membrane would indeed be a 75% diameter reduction, but when compared to this adjacent area, which is assumed to be normal but in actuality is also narrowed, that becomes a 50% diameter reduction. In other words, there is a built-in tendency to underread coronary angiograms. We've done a couple of studies trying to get a handle on this. These studies are not easy. One of the major items here is how do you define angiographic error? I'm not going to go into that at the moment. But these are some of the findings we found in the first study. It was based on 11 patients, 61 coronary arteries or portions thereof. These angiograms were read by 3 expert angiographers, and the patients died within 30 days of the angiographic procedure. In the arteries narrowed at necropsy, up to 50% or less in cross-sectional area, there were 11 arteries or portions thereof, and there were no angiographic errors in that group. In the arteries necropsy narrowed 51 to 75%, there were 8, and 7 of those arteries were underestimated by all 3 angiographers. There were 42 arteries narrowed at necropsy at some point, 76 to 100%, and 17 of them, or 40%, were underestimated by 2 or 3 of 3 angiographers. Now, we learned something from that study, and that is that there was a tendency to underread narrowing of the left main coronary artery, and everybody knows the major problems with severe narrowing of the left main coronary artery. There were a lot of studies during the 1970s showing how bad it is for patients to have severe narrowing of the left main coronary artery, but not a single study mentioned the possibility of an error in angiographic interpretation. Now, this is a study done primarily by my colleague Jeffrey Isner. It was set up the same way as the previous study, but we studied 28 patients, 28 left main coronary arteries, in patients who died within 30 days after the angiographic procedure. Out of these 28 left main coronary arteries, 20 were either underestimated, or the amount of narrowing was either underestimated or overestimated by 2 or 3 of 3 angiographers. That's a 71% error. Now, since there were 3 angiographers, we can multiply that by 3, 84 judgments. 54 of them, or 64%, were wrong, usually underestimates. Out of these 28 patients, there were 12 arteries narrowed 76 to 100%. 6 of them were underestimated. 36 angiographic judgments, 16 were underestimates. Now, this area of narrowing, 51 to 75% in cross-sectional area, is a no man's or no woman's land. Here we had 12 arteries. All 12 were underestimated by 2 or 3 of 3 angiographers. There were 36 judgments, 34% of them were underestimates. There were even 4 arteries which were narrowed minimally, 26 to 50%, and 2 of them were overestimated. So the point of this is left main narrowing is a tough artery to really read accurately. It's short, it's about 1 centimeter in length as a rule, it comes off the aorta at varying angles, but why, in conclusion, is there a tendency to underestimate degrees of coronary narrowing? I think that it's the diffuse nature of the coronary atherosclerosis in patients with fatal and I think simply symptomatic coronary disease is the major cause of the angiographic underestimation, because more narrowed areas are simply compared to adjacent less narrowed areas which are considered normal. Now, does this have any application to the patient one is considering for a bypass operation? Now, here's an angiogram of a right coronary artery in a patient who had severe angina. The injection of contrast material in the left system showed severe narrowing of the LAD in the left circumflex. Now, the right coronary artery angiogram was interpreted as showing possible minimal narrowing, but certainly not enough to warrant the insertion of a conduit. So this patient underwent bypass operation and had a conduit inserted into the left circumflex system and into the left anterior descending, but not into the right. Was that the right decision? We saw that patient at necropsy, unfortunately, 3 days later. And this is the right coronary artery. Each one of these numbers represents the number of centimeters from the aortic ostium of the right coronary artery. Now, the thing to see in these arteries is that there's a pretty good lumen here, and it stretches all the way from one diameter to the other in virtually all of these segments. So when the lumen stretches all the way across, irrespective of how much narrowing, that can certainly produce a more normal picture angiographically and hide some degrees of narrowing. Here at 8.5, on the other hand, it's a good bit of narrowing there. The other point to make on this slide is that every one of these 5 millimeter segments has atherosclerotic plaque in it. And that's always the case in patients with fatal disease, and I think simply symptomatic. Now look at that. All segments have a plaque in it. Would you know that from looking at that coronary angiogram? It looks pretty good. And there is a tendency to underread these things. Now, based on patients such as that, my colleague at the time, Bruce Waller, and I did this study. Now what we did was look at the native coronary artery, not the conduits, in patients who died following an aortocoronary bypass procedure. The patients were divided into two groups, those who died within 60 days of the procedure and those later than 60 days. And we looked at the native coronary arteries which were bypassed and those not bypassed in B. Now the reason these arteries were not bypassed was the judgment was made following angiogram that there was not enough luminal narrowing in that particular artery to warrant the insertion of a conduit. We looked at these arteries later, and this hatched area here represents the percent of segments narrowed 76 to 95%. In the black, the percent of segments virtually totally occluded, 96 to 100. The point of this is that there was no significant difference in the amount of narrowing in the native coronary arteries which were not bypassed compared to the native arteries which were bypassed. And it did not matter whether the patients died early or died late. Now, I conclude from that study that if I had to undergo a bypass operation and 2 of my 3 native major coronary systems were narrowed, I don't really care what the angiogram shows on the 3rd system. I want 3 conduits inserted. I want conduits to all 3 major systems. I'll take the chance in the 5% that one is inserting a conduit which is unnecessary, but I think 95% of the patients will be greatly benefited by that philosophy. This diagram simply shows that concept graphically. If one looks at the native coronary arteries in the patients who had a conduit inserted versus the native arteries which did not have a conduit inserted, because angiographically they looked good, there was no significant difference in the amount of severe narrowing at necropsy. Now this slide looks at another group of patients dying early, dying late after bypass operation, and simply looks at the percent of segments in the native arteries narrowed greater than 75% in cross-sectional area. And it shows at the site of the anastomosis, the percent of segments narrowed greater than 75% was relatively small. Distal to the anastomosis, about 35% of the segments was still narrowed greater than 75% and proximally higher than that. So the surgeons are doing a pretty good job in picking the anastomotic sites according to this study. We are living in the coronary thrombosis era again because of the streptokinase movement now. I think it's interesting, however, to to reconsider the problem of a thrombus in the coronary artery. I believe in thrombi. I think they're the major cause of these atherosclerotic plaques in the first place. But how significant is thrombus at the time of myocardial infarction? If I had an acute myocardial infarction today, I would be interested in having streptokinase put in me, whether intravenously, as we'll hear later today, or in a coronary artery itself. But I think that we have to remember that thrombus at the time of acute myocardial infarction is the tip of the iceberg. For example, this is a study that Dr. Waller and I did a while back. We took coronary arteries which had thrombi in them. These were patients with fatal acute myocardial infarction. And we looked at these segments that contain thrombus, cross-sectional area, in the 2 centimeters distal to the thrombus and the 2 centimeters proximal to the thrombus. And we asked how much of the artery was already narrowed by atherosclerotic plaque and how much of the narrowing was due to the thrombus itself. And what we found was this. At the site of the thrombus, the amount of luminal narrowing by atherosclerotic plaque varied considerably from 33 to 98%. But the average amount of narrowing, cross-sectional area, produced by atherosclerotic plaque at that site was 81%, meaning that on the average, the most that the thrombus could occupy was 19%. Distal to the thrombus, the amount of narrowing on a mean by plaque alone was 81%, and the amount of narrowing proximal to the thrombus by plaque alone was 76%. So I would conclude from that, really, that the importance of a thrombus, it may be very important, I think particularly important early, but compared to the underlying atherosclerotic plaque, the thrombus occupies a relatively small area. Now here, for example, is a cross-section of the coronary artery with a thrombus. Here's the thrombus right there. Now which would you rather have, the thrombus or the underlying atherosclerotic plaque? That's a nickel, and this is a $5 bill in comparison. I'd like to change directions here the last few minutes simply to ask, what are we going to do about this epidemic which is hitting the, quote, developed nations of this planet Earth? I have always been intrigued by these epidemiologic studies which show people living in some parts of this planet have very little coronary disease, very little atherosclerosis, and other people living in other areas have a tremendous amount. Now, why the difference? Are people really different, so much different in Greece than they are in the USA? I can't accept that. I'm a cholesterol man, so to speak. I'm tremendously impressed by these studies which show that when the average cholesterol level is under 150, that these populations simply do not get atherosclerosis. I had a trip to Central Africa a number of years ago and looked at coronary arteries in older people, and I looked at aortas, and one simply did not see atherosclerosis. These are people who have total cholesterols of 110 or 100 or 90. In this country, this is some data produced by the director of the most famous research institution ever put together. And this is what he says. You start worrying about a total cholesterol level in a patient under 29 when it reaches 240, or here 270. You don't tend to have to worry about it so much prior to that time. Really? I was at a party in Washington a while back, and the hostess said, well, that's a doctor over there, and this senator came up. I don't go to many of those type parties, but this fellow came up and he said, look, Dr. I went to my own doctor this week. My cholesterol was 225. He was so happy, he was elated. And I said something nice to him, but what I really wanted to say to him was that, Senator, do you know what the average cholesterol is in patients in coronary care units across this country with acute myocardial infarction? And it's 225. So what we're calling normal in this country is meaningless. It's meaningless. Here is a normal cholesterol, in my judgment, is less than 150. That's about what it is when you graduate from high school. If we could keep our cholesterol levels what it is when we graduate from high school, or our body weights at that thing, every food that's good is high in cholesterol. That's the problem. That's a challenge of our country. But it's very unusual to see acute myocardial infarction or any coronary events in patients with cholesterols 130 and 140 and so on. It's very difficult to have those levels with Marriott food chains and this kind of food that we're exposed to all the time. These are coronary arteries in a woman whose cholesterol was about 600. She was 29 years of age, died suddenly. 29. This is her aorta, terrible atherosclerosis, age 29. This is her, look at that abdominal aorta, 29 years old, 29. This is a descending thoracic aorta. It reminds me of a story Mike DeBakey used to tell, the surgeon from Houston. You know, he thinks we all sleep too much. He says whenever he looks in at the aorta, he always sees more plaquing on the posterior surface, the back, than anywhere else. Certainly that's what it looks like in that picture. Here's another man. This fellow was 28 years of age. His cholesterol was about 700. These are these lipid deposits under the skin. But look at his coronary arteries. That's the right, that's the left main, left anterior descending, left circumflex, age 28. Now that fellow could run a marathon a day if he wished, but it's not going to help him if his cholesterol is 700. That's what's got to be gotten down if these exercises and other things are going to do so much good. This is aorta. Looks like a 90-year-old maybe, but he was 28 years of age. This is an interesting situation here. I show it to point out that it's important to know, as Fredrickson and Levy and those individuals have pointed out for years, what vehicle the cholesterol is carried in. This was a patient who was 31 and had not a single atherosclerotic plaque in his entire body. He died from pancreatitis, but his cholesterol level total was 1,700, and his triglyceride level was 4,500. But it was carried in these chylomicrons, these very greasy, oily things that slip through the fingers. I like to think that cholesterol and chylomicrons would be wonderful for all of us. It would tend to grease or oil the surfaces of these arteries and prevent anything from being deposited thereon. There's another way to prevent atherosclerosis. This woman did it. She was 55. That's the best looking artery I've ever seen in a 55-year-old. She drank too much. The problem with alcoholism, cirrhosis of the liver, is that one has to make a commitment. If you stop short of cirrhosis, you get more atherosclerosis, not less. One of the interesting things in this country, the health is improving, as we all know in this country, but the amount of this high cholesterol stuff is diminishing. The amount of the Texas beef people are advertising because the amount of beef eaten by an American per year has dropped from 157 pounds to 127 pounds. They're getting worried. I think it's wonderful. Cigarette smoking, it's dropping. If you want to be healthy, you can't smoke cigarettes. There's just no doubt about it. Systemic hypertension, a devastating condition. If you go through Central Africa, they're blowing their heads off with systemic hypertension. It's awful, but they don't get atherosclerosis. If you can have a very high blood pressure, and if your cholesterol is 110, it doesn't accelerate atherosclerosis. But if the cholesterol is over 150, it's terrible. But systemic hypertension is so frequent in this country. Stroke would virtually disappear if we didn't have systemic hypertension. Dissection of the aorta. aneurysms of the aorta. Almost all of these people have had systemic hypertension or have it. It's a devastating thing. I think the best reason for going to a doctor is getting your blood pressure checked. But if one can have a normal blood pressure, throw away the cigarettes and throw away the beef, the health of this nation certainly would improve. I like to think of hypertension. We all know that it, quote, accelerates atherosclerosis, but that's an indirect thing, and it's a cholesterol-dependent thing. In nations where the cholesterol is low, it doesn't do it. The direct effects of hypertension is to weaken the media and cause aneurysms or rupture, and this is where dissection comes in and stroke comes in. Exercise, is it good? Well, it certainly makes one feel better. No question about that. There are some exercises, however, that are not very useful in preventing or delaying coronary heart disease. Probably number 4 would be most important there. I've been impressed by some of these studies of Ansel Keys through the years that as we gain weight, most of us as we get older, it's not overconsumption, it's inactivity that is so responsible for that. I hate to see a patient 20%, 30%, 50 pounds overweight undergo a bypass operation. I think that person has to be a little more responsible for his or her health. And I like to think that that some of this atherosclerotic process is reversible. It clearly is reversible experimentally. The yellow plaques are reversible. I like to think if one loses 10 centimeters of this anterior panniculus, then maybe some of this fat in these plaques would vanish. And if one believes in this concept, all you have to do is have less than 75% narrowing. Semi-starvation is maybe a little neglected form of therapy for heart disease. These are some data based on some reports by Ansel Keys. He semi-starved some soldiers, put them on a 1,700 calorie diet when they were about 20. And look at all these good things it did. Decreased body weight, metabolic rate, heart rate, blood volume, cardiac output, stroke, heart size. Now, can you name a drug that'll do all that? That's pretty good. Now, of course, it's a trade-off. There were some problems, unremitting hunger, depression, sense of being old, cold, no interest in sex, and so on. So it is a problem. One of the things about getting older, however, if we can prevent atherosclerosis between 18 and 65, our coronaries get a little bigger as we get older. It's a wonderful thing. We all say that aging is the #1 risk factor of all, but it doesn't have to be. We don't have to get atherosclerosis just because we get older. These are coronary arteries. Look at this. This is the left anterior descending coronary artery in a woman 103 years of age. 103. Look at it. That's pretty doggone good. It does not have to be an inevitable consequence of aging. I think it comes down to this. Why do without the things we like to do without them longer? Thank you very much.